Hello, everybody, and welcome to tonight's program with Dr. Thope. I'm just going to have you guys be signing in on this QR code, please. I'm going to take we're going to spend a couple of minutes just letting everybody trickle in and sign in. We had about almost 400 sign-ups, Doc. So I'm very excited, and we have about 130 people so far logging in. Thank you, everybody, for being here. I'm just going to ask that you guys please scan that QR code. And I will put a link in the chat. Thank you, Destiny. I'll get that link up for you in just a sec. Let me grab that link for you guys. Can everybody put where they are coming from? Alaska, that's so awesome. Hello, everybody. Arizona. That's awesome. Indiana. Very nice. I'll put me. I'm in Scottsdale, Arizona. Scottsdale, AZ, where all the cactuses are blooming. It's just so pretty. It's not too hot. The perfect time to come here if you guys wanted to. Thank you, everybody, for joining us tonight. I'll be showing this QR code again and putting the link in the chat. I am so grateful for you guys to all be here tonight, and I'm extremely grateful for Dr. Thope. She is the president, she's a board diplomat, she's an advanced practitioner, and she really has a passion for early detection, for oral cancer screening, for just being at the forefront of early detection and prevention. And I think it was at least 2 years ago that her and I got together, and she was able to write out a 5-part series on education. So I want to make it known this is just one of 5 or more courses that she has, all leading up to a hands-on surgical laser course that we will be hosting in the near future in the state of Florida, where she is from. And I don't know if you guys have heard, but in the state of Florida, they have just opened up the scope of practice for hygienists to use lasers. So I am so excited, which means that we'll be spending more time in Florida in the upcoming months and next year. So without further ado, I'm going to show this one more time. And then I'll be putting that link in the chat over and over. And then I'm going to stop my share, and then I will bring up Dr. Thope for her to get going here. And then, so let me go ahead and stop my share. Dr. Thope, can you hear me okay?
Yes, I can. Elaine, thank you so much for having me here this night. And I'm very excited about this course. And this is one topic that always close to my heart. At the same time, this is one thing that motivated me to do what I do every day. I will share my screen. You'll be seeing a lot of pictures, and that will reflect the title, the red, white, and the big C word. So that's what we are going to revolve around. And April is Oral Cancer Prevention Month, and we want to create that awareness. So it need not be just the month of April. I think this is something that is almost standardized as part of the standard care, that every patient, every visit, we are offering them oral cancer screening. And let me go ahead and share my screen. Perfect. I think you can see my screen, right?
Yes, we can.
Excellent. It's always good to have the dual screen. So I have the objectives that's listed as like oral lesions. And it's important that when we see in the mouth, any lesion is going to look in the combinations or distinct red, white, mixed, and sometimes combination of few colors within the red and white. So when we see what we see, don't get alarmed because sometimes the inflammation as well as the cancer, they may look alike. And we definitely need to pick the cancer at right time because it actually has impact on life expectancy and mortality. So I'm going to go over those details as we progress with the topic. And when we see a patient, and of course, whether they're coming in for the routine visit or whether they're coming in for specific complaint, we need to address the chief complaint. And if it is for the routine visit, we want to follow the standard of care. And sometimes we often see that there could be some incidental findings, which means that the patient did not complain anything, and it looks like a small red and white patch. What do we do about it? We absolutely need to address that, and I'm going to emphasize why and the reasons behind why we want to address that. And finally, when we see what we see, how do we give a blanket diagnosis? The reason why I say blanket diagnosis is that some lesions, when you look in the mouth, they pretty much look red, white, and the combinations, as I said. But having said that, is it okay that we throw a blanket diagnosis? Absolutely yes, because there are some standard steps of how we work this up. And all this workup will eventually give you a provisional diagnosis and a differential diagnosis. And eventually, as we do our due diligent workup, we will arrive at a definitive diagnosis, and that's when we manage. And again, as Eileen said, that this is like a 5-part series with like a ending up as a hands-on. So we will see this as a tip of the iceberg, but as we progress, I can keep you going deeper and deeper in this topic. So the challenges in early diagnosis, this is something that from the very beginning of my career, I have been like looking at these numbers. They have always been rising, which is not supposed to, right? If we deeply think about it, we have phenomenal AI. There's a lot of progress through it, but why is that number still rising? There is some key impact for the numbers rising. So the first number that you see as like 389K new cases is a World Health Organization's reflection on new cases this year. Oh, sorry, that was in 2002. And out of that, you can see almost like 50% leading to deaths. And this is not just the oral cancer, it's oral and oropharyngeal cancers. And that's definitely something that we need to think about, because this is when we identify in later stages, the mortality rate increases significantly. And a lot of times when we have the late diagnosis, even if the patient survived, the impact on their life value, the quality of life. Imagine someone losing their face and living the rest of the life. It's extremely difficult, and it has poor outcomes on living, even like drinking water and eating food. And I see this in my practice, how they suffer after that. And we can prevent that by early diagnosis. And that's the key. And any diagnostic delays could be multifactorial. For example, it can be patient-related. It can be healthcare provider-related factors. It can be systemic factors as well. So patient-related factors could be just a matter of fear. Fear that I have something, maybe, maybe not, and I don't want to hear the word cancer. And that's probably something that is delaying them to approach and get the care. I think that is something that falls on us as well, so that we give them the comfort, and we want to help them. And what if we got a cancer early? And the earlier we try to manage that with like appropriate interdisciplinary approach, taking them to a tumor board, taking them for a appropriate workup, this can be prevented. Because when we diagnose very early on, I have seen like 1 millimeter of oral lesion. 1 millimeter is pretty small, of that level of oral lesion being a squamous cell carcinoma. But the good factor about that kind of approach is that when we did the biopsy, the patient has nothing major to lose, and the patient was educated enough so that we did not have all the late consequences that we usually see in this patient. So it is possible. We wear loops, we kind of like look deeper into the tissue. So this is a possibility, and this is something that we can definitely avoid. Now, recognizing between the normal tissue and a normal variant and abnormality. So that becomes a critical factor when we look into in the mouth, and when any of these changes, like the subtle changes. What I mean by subtle changes is that I mean, we are professionals. We look under the loops and we see all the normal structures day in and day out. But if you see a deviation from that, that's when we want to start categorizing. So categorizing whether is it a normal variant or is it an abnormality. And if you see it as a normal variant, what is the analogy behind it? Why do you classify it? Is it like a standard normal variant, or is it just something incidental? Because I see what I see with patients, there could be some normal variant which is very benign. Some variants, it could be pre-malignant or malignant. So we want to categorize that. And if you're not sure, always like refer to a specialist like oral surgeon, oral pathologist, or oral medicine specialist, because they will be able to identify. And if you did the referral, you did your due diligent duty. And a lot of times I have professionals like ask the hierarchy of the healthcare profession, nurses, dental assistants, hygienists, dentists, refer the patients appropriately, and when it is timely addressed, we can definitely prevent the damage that can happen with our patient's life. And a lot of times we can also look into the clinical correlation of why this lesion looks the way how it is, or why this normal variants happen. And once you see and you arrive at a professional diagnosis, that will be the stimulant for your referral and the flow of events. And also, not just the referral, follow-up from the referral is also critically important. So I have a slide. It's histopathologic, and this is on a lesser magnification, and it's the section of tongue, and the tongue around here showing, I'm sorry, the tongue here showing oral cancer. It's a squamous cell carcinoma. And a lot of times the cancerous lesions happen to be squamous cell carcinoma, and sometimes it can be a different kind of cancer in the mouth. The other common variant could be salivary gland, minor salivary gland cancers, and then like cancers of lymph glands, lymph nodes, being lymphomas. They can also happen, but predominantly they are usually squamous cell carcinoma. On the higher configuration, you see that there are like keratin pearls, highly differentiated cells, highlighting the extent and the nature of carcinogenic nature of that lesion. And once the lesion goes way beyond the connective tissue and it starts to kind of encroach into the lymphatic nodes, that becomes like concerning. So a lot of these cancers, they kind of infiltrate into the neck related lymph nodes. And if the squamous cell carcinoma is primary, then we kind of have this is at a staged way of diagnosis, any cancer. And when we stage and diagnosis, this is mostly done what we call as like tumor board. So the tumor board is a place where we say, for example, today I'm diagnosing a lesion as a cancerous lesion, and the preliminary biopsy came out to be squamous cell carcinoma. Then it goes through a process within the team. I will refer the patient to the tumor board. So the tumor board has a head and neck surgeon, ENT surgeon, radiation oncologist, chemo oncologist, and also derm path, oral pathologist. So that goes as a team, and we discuss like what would be the appropriate step. And the first step would be to stage the cancer. And for that, the patient will have a head and neck imaging done. Cone beam CTs are helpful, but again, that's not the one that's going to do the cancer staging. So it is important that you do a medical CT with and without contrast to see if there is any involvement of lymph nodes. And apart from that, the next step of scan would be the PET scan to see and see what are the areas that has involved. So this is a thorough process. So anytime when you see a oral cancer, well, even if you did the biopsy, and have that referred to the tumor board, because that's extremely important, so that all these steps are followed diligently. So let me go to the next slide. So when you see a patient like this, and you can see here that there are subtle white areas, inflammation, inflamed areas. And as we progress in the um, area here, so I'm curious, Elaine, are you able to see my pointer, or should I use any kind of other pointers?
I can see your pointer, Doc.
Perfect. Thank you so much. So you can see here that there's like a strong red patch, and there are elevations as like strong white patches. So for me, this area would be of a high concern. And on this side, you can see the angulation. You can see the borders raised beyond the pockets, and how we commonly see as pockets. So this patient, when we did biopsy, I did biopsy at two locations. One was around here, and the other one was around here. So this one showed a lot of inflammation, did not show cancer. However, on this location, that came out to be squamous cell carcinoma. So you can see that this looks like a little bit weird and elevated, but this is all granulation inflammation tissue. However, here, because of the, this is a red patch, we call that as like erythroplakic. And this is like more as a mixed lesion. And anytime when I'm seeing a mixed lesion, that can be of an area of concern. So this one, I did not wait, and I did the biopsy right away because of the nature of how it is presenting. So the next slide, I'm going to show another similar red and white mixed. Some areas are red around here, some areas are white. Um, Genuinely, this I would call as oral mucositis in first place because of the way how it is looking. But again, as I mentioned, we can start with like a provisional diagnosis as like oral lesion. So the provisional diagnosis stating as oral lesion, the ICD-10 code is K13.70. So you can use that code, or you can use as like oral mucositis or unspecified oral mucositis as your diagnostic code. And then you can go ahead and have this like worked up or make a referral depending on whichever way you're convenient at. So for this patient, I did 2 biopsies again, and the biopsy site is extremely important because remember, as I mentioned earlier, one spot you suspect something could be, that may not be the spot, but you may see as susceptible spot elsewhere. So for these type of analysis, sometimes using the direct immunofluorescent lights or adjunctive therapies or adjunctive diagnostic tools might be very helpful. But that will not confirm, or that will not be a gold standard for diagnosing oral cancer. It's essentially to screen or to locate the location of where a susceptible sample would be more diagnostic or highly diagnostic or may confirm the pathology. So that would be the strategy. So here I did a biopsy around here as well as here. So both came out to be erosive lichen planus. So this patient had erosive lichen planus. The reason why I was like more convinced it could be because the nature of how it presented. So the next slide, so this slide, you can see that this is like a small lesion, but you can also see that hue of this whitey area. So this I'm comfortable calling as leukoplakia because it looks like a plaque-like lesion. Again, because of the hue and the field of how this has differentiated, it still may warrant 2 biopsies. And a lot of times I would take in, I use a direct immunofluorescent light in order to see the most susceptible area for diagnostic biopsy. Tall blue can also be another option that you want to use. But again, whichever type of adjunctive tools that you use, I would strongly recommend that you have to do a biopsy because that's the gold standard. The tools are just an adjunct, as it is mentioned, to help to make the better opportunity for the higher level of diagnostic specificity. On this side, you can see that you can again see a lot of differentiations, and you see like a punched out. It's a area that needs to be definitely looked at, you can always ask for the duration. If the duration is 1 week, I would always recommend keeping a 2-week rule. If nothing has changed or has progressed worse in 2 weeks, that definitely needs a biopsy and a confirmatory workup. On the contrary, if you see a ulcer or ulcerative area, not specifically like this, maybe like an aphthous ulcer or like just a traumatic ulcer, if that is not healing, and if the patient somehow says that he doesn't know the duration, I would strongly recommend doing a biopsy, because anything unknown time or unknown way of how it presented, I think it warrants, because I will, as I progress with the slides, I will tell you the reason behind why it is important. So here I'm seeing two tongue images. On one side, you see this patchy white tongue, coated. We call this as a coated tongue. And you can see some areas here being like slightly whitish, and some areas on the way back, you can see some redness. So when we took a sample, it definitely confirms something that is more as a yeast growth. But after we treated for yeast infection with antifungals, again, 2-week rule. For antifungal, for 2 weeks, either you can use nystatin, 5 milliliters, 4 times a day, swish and spit. In this case, I recommended swish and swallow, mainly because of the way of that white area that you see. That means they're having some extension in the throat as well. So for that reason, I recommended swish and swallow. And if you're going to go for topical lozenges, it's called Mycilex, or 10 milligrams. You can have the lozenge, or clotrimazole lozenges. You can have that sucked for 5 times a day. So that is a standard 2-week regimen for antifungal treatment. In case if it is resistant, you can also go in for a systemic drug called diflucan, and you can start at 100 milligram maybe a day, no more than 21 days max. And sometimes we kind of like give just 1-day dose. Sometimes it's more than adequate. So when we do the treatment, and if you still see lesions, then you can definitely progress to doing the biopsy. And on the other side, you see this like slough and coating, and not much of erythema. Pretty much rest of the area of the tongue looks quite normal. But having said that, when we kind of took that smear from that, and when I take the smear, more than a culture, I would recommend periodic acid skiff staining, which we call as a PAS staining, so that will highlight the hyphae, and it came out to be candida. And below that, we could get that scraping. There was some reddish nature, but that was just the inflammation. And you can see some level of the erythema on the back drop. So again, in this situation, if the erythema is like severe, and you can recommend the antifungal, as I said, that may have some systemic intake as well. So on the next slide, so this patient, you see pretty much quite a normal mouth, some inflammatory areas. But the catch was that this patient could not open beyond the opening that she has been showing here. And when we palpated on the sides of the cheeks, I could feel that fibrotic nature. And the diagnosis made for this patient was submucous fibrosis. And it is difficult to do biopsies in this patient, mainly because of the limited opening. But once we harvested the sample, and we did, the biopsy came out to be the oral submucous fibrosis. And when we asked about the history, and again, here the history is important, you may be able to appreciate the stain. She has the habit of betel nut chewing, and you have to do this clinical correlate. Otherwise, you might miss the opportunity to make the right diagnosis. Instead, we may think it's trismus, but in trismus, you will not find the fibrotic mucosal bands. So palpation and looking deeper is extremely important while making the diagnosis. On this picture, you can see that there's like bleeding gums. Yes, it was bleeding gums. And right here, what has happened is that as I rubbed, the epithelium separated. So this is definitely not a periodontal bleeding, as in the case of periodontitis. But this is a case of autoimmune condition, and this is mucous membrane pemphigoid, where it has blistered and ruptured. And when you have the rubbing, it's called as Nikolsky skein. When you see that kind of nature, please don't dismiss that as a periodontal disease, because these have significant consequences. If it is not treated well, this condition tends to affect the eyes, and these type of mucosal separation can happen in the eyes and the conjunctiva. Sometimes this can lead into patient for blindness. So by doing the right workup, what it reflects in the mouth, you may prevent a lot more other impact systemically as well. So in this condition, you can see 3 different types of white lesions. So here you see slightly elevated white patch, but the white patch is very distinct. Now, unlike what I showed previously, you can see the hue. I don't see the hue, but it is very distinct and defined. And it's not too thick as what you can observe from the image. Whereas here on the second image, there is some slight variant here with like a slightly more thickened, but this is almost continuous with the mucosa. Other than this, like completely dried and checked, it is hard to see that in day-to-day, with like a salivary moisture covering or, but this was something that was brought by a hygienist, and this referral came from a hygienist. And after she has done a very thorough cleaning, she observed some patch like this, and she brought to our notice. And when we did the biopsy, in this place was mild with mild dysplasia. So the term dysplasia means that it is an altered tissue, but again, very histopathologically, there are some variants, and I'm going to explain that as we progress through the slides. So the term dysplasia is definitely a pre-malignant lesion, and which has the tendency to progress to malignancy. And on this slide, this was actually misdiagnosis, but it was caught by a hygienist and was referred. So this crown was recently placed, and we actually had this lesion sitting next to this crown placement. And unfortunately, it was missed. And then later, when she came for the cleaning, almost 3 months later, for the follow-up, this was picked up. And it was not sure if this was there by the time when they placed the crown or not. But in the context and the extent, it is possible that it was there already. Because the crown placement time, when they took the picture, there was some differentiation. The reason why I emphasize this is that when I did the biopsy around here, this showed significant dysplasia, and it was a severe dysplasia. So it is very likely that with this severe dysplasia, if this is not taken care and if it was not brought to my attention or any of this provider's attention by hygienists, we would have missed that, and there is a high chance that this could have progressed to oral cancer. So this is one of the key times. I insist that, like, whether we are doing what we are doing as a routine care, it's important to do a oral cancer screening. Now you see here, it's a very normal tongue on one side, but slight redness, and there is some variant around here. So what's happening here? So this patient has a tendency of rubbing this tongue against this teeth, and she came with a complaint of oral burning, constant oral burning. And this patient had a burning mouth syndrome. This is the subtle change as a benign migratory glossitis, because when we observed in the 2-week rule, remember, I had her come in to consider for a biopsy. It was completely gone. And then the burning was still persistent. And this was something it's triggered from this end by rubbing against the tongue because it was itchy. So that is a classic sign of someone who is having a benign migratory glossitis along with the oral burning sensation. And will that be a classification of burning mouth syndrome or not? It kind of depends on their workup. So burning mouth syndrome diagnosis is a diagnosis of exclusion. So on this picture here, you can see some patches, and many of you have picked. This is definitely HPV. And once you see HPV, that puts the patient at a higher risk for oral cancer. So definitely have this worked up. and the diagnostic procedure should be followed, and made sure that this is definitely which type of HPV. And depending on the diagnosis, the lesion could be ablated. I use lasers a lot. I definitely use ablation because this is like one specific area that shows this papillary changes. The rest is pretty much normal, but some patients may have a wide range, and that will be very difficult to laser. So this patient had a good opportunity to have the laser done, and the source was taken care. The benefit of a standard biopsy procedure with a laser procedure, they heal really well. And this is a difficult area. If you did a scalpel and then suturing it can be difficult. With laser, it was ablated after harvesting the biopsy tissue. So on the next slide, it is a very interesting patient. Both patients had a common diagnosis of sleep apnea. They were both wearing dentures. They're two different patients, and they were not removing the dentures because of the way how they were closing their mouth with the mask on. They did not feel comfortable. So they wear the dentures and have the CPAP machine and then sleep, and eventually the dryness and the level of impact created the coating. This is definitely a pseudomembranous, because we could take the slough off. It's a pseudomembranous candidiasis, and we had to do our management plan so that it is cleared, and we have to refit the denture. And also we recommended highly have to have the denture taken out at bedtime, so that but we also had different CPAP arrangements. Instead of the mask, they went for the nasal hood. So something what you do can have a different impact. Now, imagine having the CPAP machine with this type of inflammation. So the primary complaint what they had was this referral came because of having the mouth burn. And when we took the dentures out, this is what we found. And until that time, it was never made. Because one, they're not seeing the dentist because they don't have teeth. Two, they're comfortable with the dentures, and then they're having their CPAP machine. Now you can see how much this could be missed. And in particular, this patient, if you notice here, so that was a dysplastic tissue. The reason it could have been dysplastic could be because of the persistent inflammation, and also the level of candida. And the study shows that if the candida is present, they may stimulate the tissue changes and can be a predisposing factor for dysplastic changes. So this, if we did not make a prompt, timely visit, this could have progressed to oral cancer. The potential of having this, if it is not noted appropriately and had not taken care at the right time, then that could definitely progress to cancer. So on this side, you can see a lot of hue, and this patient did not have any need for biopsy, because once we put them on antifungal and reevaluated and changed the sleep app machine mask to nose hoods, they almost resolved. So again, the 2-week rule applies with the antifungal if they're showing progress and if you're on the right direction. So this one, you can see a small patch. And again, this was sent to me by hygienists. Again, this did not respond with the inflammation, and there was some red patch that was sticking there. And the red patch actually prompted, because anytime you see a strong red, it is definitely scary. And this was definitely dysplastic. This is the erythroplakia. And the chance of erythroplakia turning into malignancy is slightly higher than white patch. The erythroplakia has 14% opportunity to become cancerous. Leukoplakia has about 7, slightly higher than oral lichen planus. Oral lichen planus has a lot of variants. So the common variant is just a basic reticular pattern and a mixed pattern with like white plaque-like lesions, along with like erosive lichen planus presentations. When we have this mixed combinations, the chances of becoming dysplastic and progress to cancer can rise up to about 7%. Sometimes it's very subtle and the progress can be less than 1%. So a fair chance and significant studies says that the oral lichen planus malignant transformation can range anywhere from 0 to 7%. So this patient, I can still remember the day that they came in from a nursing home, stating that the denture does not fit anymore. So this is an upper lip area, lower lip area, the palate, and you can see one side of the palate very intact, the other side of the palate, buccal vestibule, and this is the lip. And this is definitely squamous cell carcinoma without me looking into it. Now, this has been the progress for not being attentive. And again, this patient lives in a nursing home, and this actually prompted, and we got a grant to educate the nurses about this oral cancer evaluation and screening. And the nursing homes have a minimum data set. If some of you are in geriatric mobile clinics or home care, definitely want to have this reminder of this minimum data set that the nursing homes or the homes need, and it will be our due diligent responsibility to train the nurses to be able to do a quick exam. And now the Medicare and the home health is extending some codes for the nurses to be able to offer this kind of screening or maybe even fluoride treatments. So that's a new change happening now. And I'll show you a few more non-oral cancer, but still can be scary looking. So this is healing herpetic lesions, and you can see the areas of vesicles formed into ulcer, and it's more as a healing ulcer. So this picture of tongue is a benign migratory glossitis, but these red areas, when we scraped, it had some fungal growth, and we call this like a scrotal tongue because of the nature how it presents. And this is a patient, it was sorry, erythema multiforme. And this patient had acne and had taken antibiotics. Following the antibiotics and the allergy from the antibiotics, she happened to have this kind of severe lesions. So this is systemic erythematosus. And here you see a lesion. This is an aphthous ulcer. It's very much like a distinct single aphthous ulcer. This is an aphthous ulcer that's almost healing, but you can still see the halo redness around that lesion. This is a viral lesion. It's a herpetic lesion. You can see that small crusty herpetic vesicles that's combined. And this definitely can be something that you can confirm by confirmatory diagnosis during the doing the lab tests. And here, this patient actually has viral lesions, but what he did is he applied something topical. He was thinking that if he applied Ambusol or over-the-counter product, but thinking that he's going to treat with that, self-treatment has ended up having this like angry-looking appearance, and these are the vesicles. You can see more vesicles popping up here and another distinct big large vesicle. And we treated with antivirals, and it responded. Within 3 weeks, it resolved. So this lesion is a normal variant. It's a lymph nodule on the back of the tongue, and you can see more lymph nodules here. So we can call this as the lingual tonsil. Sometimes you see this and ask the patient if he has any allergies, and some with allergies or postnasal drips, you can see this slightly inflamed. But if the patient is alarmed, concerned, make sure this is benign and then reassure. Do we need warrant for the biopsy? Again, this is definitely like pinkish, looks similar to a lymph node. But if you see anything beyond ulcerated, please palpate. I know this is a very difficult area to palpate. They may have gag reflex, but please do palpate. If you have a variation with the palpation, definitely it warrants a biopsy. So this is basically a cheat sheet of how oral lesions, red, white, and variations in this colors might happen. And we have the categories as infectious, immunologic, and other could be traumatic or malignant. So we would look at if the lesion is like primary single, is it recurrent, And these are the key questions that would be essential in order to make a differential diagnosis. And if the patient says that they don't know and you're making the incidental finding, please make a 2-week roll, follow up, see if it is healing. And sometimes see a lesion, and empirically, I have seen providers recommending antibiotics. I don't think that would be more appropriate, because sometimes having to treat with antibiotics can have consequences on what the kind of diagnosis that we are making. Can you use antifungals again if you're sure and if you're seeing the trend of like either white coating, erythematous nature? Yes, you can try antifungal. And a lot of times I see providers using magic mouthwash, but magic mouthwash is a broad umbrella term. And again, you may have any type of ingredients in it, but make sure if it is purposeful. If you're having a steroid or an antibiotic in it, just know what you're seeing, and if you need to add it, you can add it. But at the same time, if you're not treating for the targeted lesion, don't empirically add it, because it may have other consequences. When they use it, it may initially heal, but that you're empirically targeting or doing a blind sweep on this, that may actually have a immediate response, but then later sit and may have a development of dysplastic or malignant tissue. So know what you treat, and in that way that we make appropriate opportunity for a confirmative diagnosis. So the etiology of malignant transformation for any potentially malignant lesions can be because of the genetic or epigenetic alterations, or any kind of habitual factors like smoking or betel nut chewing, as I mentioned, alcohol use and DNA mutation. And sometimes what we call as DNA mutation is that on the markers, if you have some P53 mutation seen, and I think there are some tests that you can do it, but again, none of these are highly specific, and the gold standard is always doing a biopsy, looking at the tissue biopsy and the cells. And now there are a lot more evolutions within the diagnostic opportunities, and which something that we can discuss in depth during our future webinars and future sessions. And again, histopathologically, if you see something as like oral pre-malignant lesion, we want to see what stage it is, and it needs to be categorized appropriately. And essentially, the key is that the follow-up protocol is extremely important. It is not a passive examinations. Sometimes we do active monitoring as well. What I mean by active monitoring is that you use adjunctive monitoring tools in order to effectively assess the progress. Now we have a good tool that we can do photographs or pictures for our cross match and cross comparison to making a definitive diagnosis. So addressing these patient complaints. So anytime when you see a lesion, when you communicate, that is when you can either make this patient like highly concerned, panicked, worried, or you can calm down and tell that this is nothing to worry, lose the track of the lesion. So optimal communication, that is the key, optimal communication. What I mean by optimal communication is conveying what you see, not triggering the fear factor. At the same time, be confident that you have a protocol in place so that even if it comes to be a cancer, they are in good hands. And make sure that if it is an early diagnosis, the communication is one of the key factors. And a lot of times providers fear the communication. And believe it or not, I have heard from even medical oncologists, radiation oncologists, who may have even switched their profession to radiation oncology because of communications. So I still remember one of the conversation that I had with a radiation diagnostician, so that like he mentioned that, Doc, this is a difficult conversation. I'm going to leave this to you so that you can communicate to this patient, and we can follow the protocol. Because sometimes you can tell the big news and you can see the whole family crying. And I have been in that position, and using appropriate communication methods is extremely important with this patient, so that your providing the empathy, you're providing the strength for them to go through what they need to go through. At the same time, the phase between what you see and making a confirmation with the diagnosis and then the progress to the future treatment, this is like a crucial phase. And then definitely, this is something that I'm going to cover in detail in our future sessions. And again, cultural competency, sometimes depending on the cultural nature, the communication could be exclusive to the patient, or it could be to the family first. I have been in multiple opportunities in the way how patients perceive how the care needs to be. So definitely have this cultural competency, but end of the day, it is the patient's trust and making them as comfortable as possible with our communications. So when we do the exam, this 90 seconds can be the key factor. And again, in this, we can focus on the extraoral, and all these dots, what you're seeing are the potential locations where the lymph nodes are. And anything you're feeling more than a small pea size, fibrotic, uh, non-tender, freely mobile, that's because of previous inflammation or previous opportunities why it is that it is there, and it is never going to change. And always, again, have the 2-week rule, tenderness, and exam. Other than that, if you feel like a big knot, I would definitely recommend progressing to the next steps. On the intraoral, from the very first day from the dental school until for the past all these years, I follow a standard, my checklist. There's like no right way or wrong way, but make sure you have a standard and don't violate from the standard. When patient comes and says that, hey doc, I'm having a lesion in here, I always tell them, okay, I'm going to do my steps so that I don't miss anything. A lot of times when we retract with the mouth mirror, the lesion can be just below that mouth mirror and it can be hiding. So always have the step so that you don't miss anything. And it just takes 90 seconds. The key to do a palpation technique is that if you have a ball and you have a cushion pad and you compress it, it's going to dip in, and that's not the right technique. You have to have a table formed and then press it against the table. You will feel that lymph node or the mass be on your fingers, and you can palpate it. And that's the right way of doing the palpation. So for the extraoral and intraoral examination, if you did it right, you're not going to miss any spots. And again, this is the illustration of how you look at and target areas. And again, if you have a cheat sheet, it need not be any way. You can have your own way of looking at the tissues and examining, but always have a pattern and follow the same pattern so that you don't miss any areas. So clinical warnings and red flags are some sore, irritation, lump, thick patch in the mouth. Again, the key is that if they have something and if it is not painful and if they don't know, that is all key red flags. And if they say difficulty swallowing, not able to open the mouth, palpate, and if you're not able to resolve, if it is not a trismus or TMD, I would strongly recommend doing a next stage as like imaging studies, because I personally have fooled myself, not necessarily very early in the career. I felt that the limitation could be just the TMD, but I had seen squamous cell carcinoma at the base of the tongue, but it was still like early because I keep monitoring. The 2-week rule helped me getting to navigate to that early diagnosis. The second chance is that it can be a benign or pre-malignant lesion as like oral submucous fibrosis. So don't eliminate that. On some occasions, when you have salivary gland swelling, parotid swelling sometimes can limit the jaw opening. So these needs some extra steps in working up those patients. So I mentioned in the early presentation that these are the progress. So when you see a normal mucosa, it's more plain. And when you see a dysplastic changes, you can see that there is like thickening, which is the hyperplasia. And dysplastic changes starts to happen around here. And as it starts to change, we kind of look into the histopathology. And as we do more in our future sessions, I will go through that in depth. And again, like the variation starts to happen in the basal layers. And when it starts to invade and fully differentiate, it can create that carcinogenic change. And sometimes these progress need not be from mild, moderate to severe, and then carcinoma in situ, and then carcinoma. It doesn't happen that way. A mild dysplasia can, in 3 weeks, change into carcinoma. Remember the previous slides that I was talking about, the epigenetic, genetic factors, and the perfect climate for that to change, and along with the genetic mutation with loss of heterogeneity. So what I mean by loss of heterogeneity is that when you have two sets that is not similar, you have this ability to fight against it because of the diversity. On the contrary, when the heterogeneity is lost and they started to behave the cancerous way, the transformation is much faster into malignancy. Let's see. Okay, why is it not? Okay, there we go. Then the incidental findings we can see as like a routine exam. You find something, please document. Pictures are exceptionally good because it's like more than 1,000 words that you can put in for one picture. So pictures are the key, and you can always tell the patients to take the pictures. Now we have smartphones and it is much more advanced. If they have anything, I recommend them take the picture, send it to me, and then by the time when we accommodate the patient within a week or two, you still have one, and the 2 week we are utilizing the time frame if you cannot accommodate them immediately. And again, if we have everything documented appropriately and due diligent process of either you managing with the appropriate steps or making the referral to be seen, and you have followed through that they had an appointment, they were followed by a specialist, then that eliminates the legal or ethical complications. Otherwise, this is one of the key areas where you have the medical legal implications for misdiagnosis, especially if it becomes cancerous. So significance of early diagnosis, as I mentioned, by all means, if the patient lived, they have a higher quality of life, and that's extremely important. And again, the earlier diagnosis saves lives because the 5-year expectancy for late diagnosis is significantly lesser. And a lot of times, if it is diagnosed late, we have life concerns and life complications. And for the profession, it can be a medical legal consequence too. And it's important that you have your records appropriately maintained. Remember one of the pictures that I showed you where they had placed a crown, and the picture after the crown showed some level of this lesion, which technically means that they missed. But the good news is that they still had their hygienist when they came in for the cleaning visit. They caught and appropriately managed. Though the window was like small, it still has the spur for the medical legal consequence. But again, if the patient is more compliant and you have done a due diligence step and made your referrals, that will minimize the medical legalities. Prevention strategies, early detection protocol, have that placed in the office. Train each and every team, have the calibration so that this will minimize anything associated legal if it ever happens in your practice. And ethically, I think we have our due diligent responsibility of doing a thorough exam, intraoral exam, extraoral exam, and having that correlated for their medical conditions or the laboratories or lab, I mean by the blood work or if their general health statuses. So this will give a sketch of what and how the flow happens. So we have history of present illness. Say if the patient knows when it happened, or if they did not know when it happened, it still needs as the history of present illness. Correlate that with the medical history, which will help you to identify or get a trend on what kind of lesion is that, given the fact that there could be autoimmune issues, there could be even the CPAP, as I mentioned, or if they are in immunosuppressive medications, or if they are on steroids, it could be oral candidiasis. Probably, if you had the lesion long enough It can have some dysplastic changes as well. So having that in the medical history will also give you an exam, definitely extraoral exam, intraoral exam. Then formulate a provisional diagnosis. A provisional diagnosis is as simple as telling that it is a non-specific oral lesion. Or a differential diagnosis, if you can, then it could be whether it is a yeast or sometimes it may be a multiple diagnosis. What I mean by multiple diagnosis is that anything you see as red, white can be yeast infection along with oral lichen planus. That means it's two diagnoses, not just one on what you see as red and white. And then always have a protocol for your next steps. Either it could be a referral, it could be a diagnostic workup, and have a confirmatory diagnosis. Once you have a confirmatory diagnosis, communicate that effectively with the patient, have a protocol in place, and once you have a lesion, you have to actively monitor at specific intervals that will prevent them or provide them opportunity for early diagnosis or prevent them from having a late possible diagnosis of cancer. And that would be my end. Let me stop sharing and let's open up for any questions. Eileen, I think you're muted.
Really good, docs. Top notch. A lot of good questions in the chat. Would you mind, Doc, if I read some of them to you?
That would be really good.
Okay, so going back to the beginning of your program when you were showing the Candida slides. So there was a question of what causes the Candida?
So that's a great question. So the candida per se is one of the commensals of the mouth. What I mean by that is that they are there in the mouth. You're not going to get it from outside. They are one of the microbes of oral microbiome in the mouth. So what and why it happens as a candidal infection is that it's opportunistic, which means that opportunistic, yes, which means that when you have the mouth more acidic, which means at acidic level, depending on the acidity level, the good bacteria starts to go down, the bad bacteria and the fungus starts to overgrow. When you have antibiotic, it actually targets the bacteria, not the fungus. When you're on antibiotics, that's when the fungus grows. I give this analogy of, say, for example, you have 100 seats and it has to be always occupied. That's how oral microbiome works. And when you take the good bacteria out, the bad bacteria fills in, and the fungus has an opportunity to fill in if the potential is right. So,
Okay.
yes, Candida lives in the mouth and it is an opportunistic infection. And when you have a perfect climate, it can manifest as an active or long-standing infection.
Okay, very good. And I had another question for HPV lesions. Should they always be removed, or is it safe to still clean due to aerosols with active lesions?
So be mindful. This is like highly technique sensitive. I don't want to just give away a statement here because this is something that has like a specific protocol of follow-up to it, and depending on what you see and who you see in. Because I can give you a nugget of information. If the HPV lesion is in HIV patient versus immunocompromised patient versus just like a patient who has higher level of potential with cancer. Remember that all the lists that I said that would put someone to have a higher susceptibility for oral cancer versus someone who just got like one HPV lesion. So the protocol and the standard of approach is extremely different. And in case of doubt, anything that would stimulate the virus to get inoculated at a different place, you need to avoid that. What I mean by inoculation is that if there is a raw area, like a sore area, or if you just finished scaling or any dental procedure which has the potential as like an open wound, you have a potential to inoculate active viral lesions.
Okay, very good. Another one on lesion. How frequent, also on HPV, how frequent are lesions precancerous? If a patient has an active HPV lesion, is it easier to spread versus having the virus but not having an active oral lesion?
I would say that this is definitely more of like a deeper topic, and
Yes.
it's difficult for me to give like one statement. I don't want to give that
Yeah,
one statement and say, okay, yeah, when I want to give any information, I want to be thorough on what I'm giving. So,
absolutely.
yes, yes. And they are very case specific. I can tell you that.
Okay. When using the laser to remove an HPV lesion, how do you know you removed it all?
That's a great question. Again, when we start like doing layer by layer, I think that's how
That's
it's more meaningful. And when
okay.
you see a very clear, distinct, normalized tissue, that's when you would stop. And you wouldn't go more deeper than, the level of possibility. So don't get and hit the bone by lasering. That will be too much lasering.
Okay.
Okay.
Here's another one. I recently had a patient with black coated tongue. He's being treated for stage 4 colon cancer. The doctor recommended a tongue blade. Is there anything else that we can recommend?
I would be a little skeptical about using the tongue blade because, again, tongue blade can be very technique sensitive. I would recommend, there are like medications, prescriptions that we recommend to take the black coating off. It's usually like Dakin's solution. We dilute the Dakin solution in order to like brush off the tongue. So the coating can be happening because of the chromogenic bacteria in the mouth, along with the extended filiform papilla. So when you have this papilla spread out, and then this is like kind of giving you a perfect climate to capture that. Remember the classroom of 100, and you have more seats, I would say, in between the seats so that they can have the bad bacteria and the chromogenic bacteria built in that's creating the coat, along with the food stains and everything. So that is why you're getting the black coating. In order to remove that, it's similar to you have a bad tile. I mean, that's not fun to think, but if you have that scum, you scrub it off. So instead
Yeah.
of like scraping it off, you see what I'm
Mhm.
talking about? So I
Yes,
would
yes.
recommend either using just the baking soda or Dakin solution, or even some simple like oils, and then like rubbing, instead of rubbing, you just use circular motion to debris that, like just like mop that area smoothly, gently, because that's like light tissue, and that will help to remove that coating.
Okay, very nice. And I've been known to take the Cavitron on the lateral side, just lower the water a little bit and just kind of go over the tongue laterally as well.
Yes,
Another good one, can squamous cell carcinoma show up on two different areas of the mouth, say
absolutely.
upper anterior, lower left facial,
It is
but
possible. It
oh,
is possible, yes. So
okay.
I often see that kind when patients do the dipping, and that like triggered the cancerous lesion. So when depending on the areas they are dipping, again, this is a great question because we are looking at a big blanket. So take a lawn, and you have like a area prone for weeds and prone for changes. And no matter what, if it is like a loss of that texture anywhere in the field, that has the potential to become cancerous.
Very nice. Let's see. Are there any other questions so far? There was another one I saw. How often are you using light detection? So I know you talked about using like a bioluminescence. Are you using blue light detection like with the Velscope?
I do, yes. So as I mentioned, I pretty much use it for active monitoring. Remember, I mentioned the word active monitoring. What
Mhm.
it means is that not just seeing passively or like doing like a basic exam. If you know what you're looking for and you have a trend of where all the patient presented with the lesions, you definitely go into those areas with the light, intentionally see that through the light if there is any kind of light uptake. So that would be something that if you see that there is a deeper uptake, then you follow up that with biopsy. So that is like your lineage between active monitoring. But what it is not is that when the patient comes in, you just show light, and then that's not how it is supposed to be. It is supposed to be on a patient with like a very strong sound protocol. You use the light as an adjunct, but not as a sole mode of making the diagnosis.
Okay, very good. And at the completion of this, I'm going to go ahead and send you guys the outline of Dr. Thope's program, and so you guys know what's to come. There was a lot of questions on, you know, HPV and managing HPV. So in future classes, she will go in a little bit more depth with that because I think it's its own little piece in itself. So that's great. And then, did you guys, if you guys were driving or you're attending, you know, on the go, I know it's dinner time for a lot of us and we have families to take care of, but let's do ourselves the favor of going back and re-watching this because she was showing a lot of good photos and point references and a lot of terminology was in there. She even gave some really great recommendations on how to treat certain conditions with over-the-counter medicaments or prescription grade medicaments. So there was a lot of really good nuggets in here. So if you guys, of course, you guys are on tonight, please sign in, use the QR code and with the link as well. But also I'm going to send you the replay. And if you do watch the replay, go ahead and fill out a form submission again, and we'll send you another self-study credit for that time learning. And so the point I'm trying to make is with these courses that I'm hosting in the study club and bringing on really top-notch educators like Dr. Thope, I want to elevate us. And I don't know how many times Dr. Thope said, a hygienist found this, a hygienist sent this to me. You know, so we are at a time right now where we're really wanting to elevate our profession and really remind ourselves of how impactful, you know, we are as clinical hygienists in, you know, in interdisciplinary care with providers like Dr. Thope and our general dentists we work for and so on. So I'm very inspired. Very good, Doc. I really greatly appreciate you. Does anybody else have any other questions or anything else to add before we end the program for tonight?
So I see two questions that's listed
Okay,
and they are very important. I'm just going
please,
to quickly answer that. So
please
one
do.
is panoramic X-ray catch most bumps or lumps? No, because panoramic X-rays are more to identify bone related. But the question is that can you do a panoramic X-ray on a patient? I would strongly recommend because a lot of times the cancers that's missed is when we do just the intraorals, a panoramic X-ray, and you see that a floating teeth. What I mean by floating teeth is that you don't have any bone around it. That's a possibility that you would be seeing squamous cell carcinoma or even like large B-cell lymphoma. And in my experience, someone missed the panoramic X-ray for 6 months, and the patient, we lost the patient eventually because
Gosh,
of B-cell large cell lymphoma. Yes, panoramic X-ray can be a highly important tool. If you see a periodontal lesion or if you feel that pocket is more than unusual, I would strongly recommend doing a pan rather than the intraorals. Because if you see a floating teeth, that is a sign that needs additional evaluation. And there's another question regarding dysplasia. So what do you do when the diagnosis comes back to dysplasia? So Laura, I don't know your background, but if you see and if you have a diagnosis of dysplasia, I would say that it is having egg in your hand and not to crack it. So that's the word I would say, because it is something that can hatch or like crack anytime. So active monitoring is the key. And know what the dysplasia's backdrop is, all the etiological factors that I was talking about. What is the perfect climate? What is the likely risk of this transformation? So yeast, constant yeast, or immunosuppression, those definitely something that you need to be highly cognitive of when you're doing the active monitoring. So active monitoring is the key for dysplastic tissue management. And again, if you have a pre-diagnostic, potentially pre-malignant lesion, like lichen planus or any of that similar lesions or leukoplakia, I would be very cognitive of trying to manage the primary lesion rather than just monitoring the dysplasia.
And
Oh,
Dr.
excellent,
Thope,
Laura. Thank you so much.
do you, Dr. Thope, do any independent consulting? Like if we were to see lesions in our practice, could we contract you to send those images, and just case studies to you to help give us some guidance? Is that something that you do at this time?
Absolutely, yeah. So
Okay.
what I would need for them is a set of details, and you have my email. It's also publicly available on my website, or you can catch up on the email. I can send you the list of what I need, and when we have the list, we can go over either if you want a report of what you need to do or how you want to manage the patient, or if you need to have like a quick chat, we have all those options.
Okay, excellent. So when we send out the CEs in a week from today, thank you guys for your patience with this. We will include that information from Dr. Thope so that if you guys wanted to send cases and really take a more interdisciplinary, more active role in detection, we have that resource. So I'm extremely grateful for that. Thank you. So Dr. Thope and I are working out a schedule to be rolling out the next classes that she's going to have. In the meantime, I would love to see you guys back for our next event. Uh, Not too long ago, we did a part one to the OPA passing of supragingival scalers, dental assistant scaling in Arizona. That was a very hot topic. And again, the reason why I have this class and clinical courses and a more high level, because this speaks to us on that scientific and clinical levels, and it's really helping us elevate our excellence. So I want to go back to an SB 1124 and do a part two. So we have that scheduled. If you guys want to go ahead and scan the code, and I'll go ahead and put that link in the chat. We are having a panel of over 7 providers, myofunctional therapist, a RDH dental practice owner, an RDHAP that does mobile dentistry and has a brick and mortar. So several advanced hygienists that are really just kind of stepping beyond the clinical chair and expanding scope of practice. We'll have somebody talking on Botox and getting Botox certified. We'll also have another hygienist who has expanded beyond the clinical chair with lasers and is now creating protocols for body lasers and is working in med spa. So a lot of really interesting people doing amazing things and hoping to inspire us to reevaluate where we are and just look at next steps. And so thank you guys. I'll go back to the QR code for Dr. Thope's event. And again, Dr. Thope, I can't thank you enough and for taking time to answer each and everybody's questions that took time to enter them in the chat. Thank you guys.
Absolutely. Thank you so much.
Okay, so this will be available on our YouTube. If you guys are watching on YouTube, go ahead and click the show notes and you'll see a link to fill out a quick form that my team will get and will issue you the CE credits. So I'm going to go ahead and wrap it up and thank you again, Dr. Thope, and we will be in touch. Good night,
Thank you.
everybody. Thank you for joining.
Bye-bye.
Bye-bye. And our YouTube is Dental Laser Integrations. I will also put that in the chat, Dental Laser Integrations. And we also host these post these on our Dental Laser Integrations website. So dentallaserintegrations.com/webinars. So I'll go ahead and put that in the chat. And if there's other topics related to detection and anything that it is in Dr. Thope's wheelhouse, please let us know because she is excellent and she will update and add to things if it's helpful, so having some feedback would be great.
Absolutely.
So for some reason, my thing is very slow. So it's going to be dentallaserintegrations.com/webinars. And then if you were to search up dental laser integrations on YouTube, you will definitely find us. So I'll be sending links out to those places as well. Okay. All right. Let's see. All right, Marcy Hill, let me get you that. And I'm gonna show the QR code again because it's gonna close. So whoever didn't sign in tonight, you won't get the CE. And that's my assistant kind of putting the hammer on us because there's sometimes people check in and it's like the next day or the next day. You have to check in tonight, okay? Otherwise, we would end up sending you a self-study CE credit, and it's always better to get live credits, okay? And let's see, there was another question. Where did you get the Dakin solution for the black hairy tongue? The Dakin's prescription?
Yes. I think I just put it to ourselves. I didn't put to everybody. So
Oh,
that's
okay.
fine.
I was making that mistake too, and everyone's like, I don't see the link. And I'm like, whoops, let me change that to everyone. Okay. All right, this was so good, Doc. I need to go. I was like trying to keep up with the chat, so I'm gonna go back and rewatch it myself and just take it all in.
Thank you so much, Elaine, for having me here today. And thank you so much for attending.
Beautiful slides. Everything was top notch, Doc. Thank you again so much. And good night, everybody. Thank you.
Good night.